with non-STEMI, the objectives here, what we really want to get across, and actually as we get into the bundle branch blocks and Scarboza's and modified Scarboza's criteria, it actually gets pretty confusing and pretty convoluted, is we always try to do. This is continuing education. So in theory, at least for the ALS providers, you all should be familiar with how to read a 12-lead EKG. We're not opposed to going back and reviewing some of that information, because I know if we don't do it routinely, clearly, that's a skill that we kind of lose. But the intent is not to go over how to read a 12-lead EKG every time that we log on. Clearly, we don't have all ALS providers or our basic providers, so we try to balance that out and make sure that everybody is getting something out of the lecture. But with today's portion, we felt that it was important to talk about what population of patients is out there that are actually having an infarction pattern that we're not going to find on a 12-lead EKG under normal conditions as far as looking for STEMI alone. So we're going to talk about the prevalence of non-STEMI versus STEMI patients, review 3 different types of non-STEMI patterns that you can find on a 12-lead EKG, and then talk about the importance of treating the patients based on their clinical presentation instead of the 12-lead EKG finding. And, back to EMS initial education, it's always been treat the patient, not the monitor. So if we can do that in some of these situations, if the patient is in fact having chest pain or they're displaying signs and symptoms of an acute coronary syndrome, then we may be of benefit to them. And I think that it'll be eye-opening to you, especially when we get into Wellens syndrome, on why it is important for us to have an initial EKG, a repeat EKG, and then ultimately the emergency department or the intensive care unit or wherever they're being admitted, they need to continue doing serial EKGs, and we'll show you why that is important here in a few. So non-STEMI patients, the median age at the time of presentation for an acute coronary syndrome in the United States is 68 years of age. Males outnumber females by a ratio of 3 to 2 for the non-STEMI. And the incidence of acute coronary syndrome in the United States is about 780,000 patients. Approximately 70% of them will be a non-STEMI. And I want to kind of reiterate that. So 780,000 patients will have an acute coronary syndrome. And out of those 780,000, 70% will have an infarction pattern that is not caught on a 12-lead EKG. I think this is important. So the reason I feel that this is important is everybody that is tuned into the lecture today at some point in time has probably been the family physician for one of your family members, right? You finish EMT school, and the next thing you know, you're getting questions about, grandma has gout, or she's got a GI obstruction, or whatever the situation is, and they want to ask you questions about it. So what do they also do when they don't feel good or they're having chest pain? Well, they call to see if you're on duty. They show up at the firehouse and they want you to check their vital signs and do an EKG. We do the EKG only to find that there is a non-STEMI pattern. So there's no ST segment elevation there. We tell them, yeah, your EKG looks totally fine. So we send them home. Well, 70% of these patients that are having an acute coronary syndrome are in fact having an infarction pattern that we are missing not only in the pre-hospital world, but also in the emergency departments as well. So the absence of ST segment elevation on a 12-lead EKG does not eliminate the fact that the patient is having an infarction. The only gold standard that we really can use, and we can't even do it, is to have an intervention in a cardiology cath lab. So our job, do the 12-lead EKG. If they're having a STEMI, sure, we need to send that in so that we can get the ball rolling. If they're not, what the emergency department is going to do, they're going to look at troponin levels, and we'll talk a little bit about troponin today and why that works the way that it does. And then ultimately, if it is still suspicious that the patient is in fact having an infarction, they're probably going to make their trip over to the cath lab for a cardiologist to kind of look around to see if the vessels are occluded. So please, please, please do not just look at your 12-lead EKG and then tell your patients or your family or whoever it is that, your EKG looks totally fine, so you don't need to go to the hospital. That is not necessarily the case. So The non-STEMI clinical presentation is going to probably end up being pressure, substernal like type pain with some radiation to the arm, the neck, or the jaw. And remember, these are all just referred findings because of the nerve bundles that run alongside there. So there are 4 groups. We always talk about this in initial education: elderly, female, diabetic, and chronic hypertensive patients do not present typically. So if you have a patient that meets any of those 4 categories, they don't have to be all 4, any of the 4, elderly, female, diabetic, or chronic hypertensive, and they're telling you that they don't feel well, that is an acute coronary syndrome for those classifications of patients. So it may be associated that they have some nausea and vomiting, maybe some syncope, fatigue, or some diaphoresis that goes along with that. Basically, what I'm trying to tell you is if they are any of those 4 classifications of patients and they have any type of complaint, it is a non-STEMI clinical presentation and they really need to be evaluated. So the different types of MI, and you all, if you've had cardiology at the advanced level, you probably have talked about subendocardial and transmural infarcts. So what a transmural infarct is, the transmural is a full thickness infarct. And there's a little bit of a misnomer here that full thickness are the only ones that will end up giving you a Q wave on your EKG. That is not necessarily the case. There's some evidence out there now that suggests that that is not 100% true. You can get a Q wave with a subendocardial infarct. It just depends on how thick it is. So with your transmural infarct, you can obviously see, this is probably the left, the thickness here is the left wall of the left ventricle. We can see that the right ventricle, the wall is not as thick because it's not under the same amount of pressure to eject blood to systemic circulation. So if we have a transmural infarct, it is going to be a full thickness. And you can kind of think about this in relation to burns, right? So a 3rd-degree burn is all the way down through that dermal layer. Same thing here. Transmural infarct is going all the way through the entire wall. Up at the top in like the 12 o'clock position, you can see the subendocardial infarct. So what they're now finding is if this subendocardial infarct is not a very thick extension into the wall, you may not get a Q wave finding with that. But obviously, as this gets thicker and thicker and goes more into the wall, what they're actually finding in some of the research that is being done is that they are producing a Q wave. So again, I don't want to hang up too much time here, but transmural infarcts were always thought to be the ones that would give you a Q wave, and subendocardial did not necessarily the case any longer. So if we have a patient that is telling us that they are suffering from an acute coronary syndrome, right? Chest pain, difficulty breathing, arm pain, jaw pain, I just don't feel well, particularly in one of those 4 classifications of patients, then we have the ability to look to see if they're having a STEMI, obviously, but if they're not, how do we make the determination on whether or not this patient is in fact having an infarction pattern? So one of the ways that we can do that is something called De Winter's T waves. So in a De Winter's T wave, this occurs in about 2% of acute left anterior descending occlusions. And I'm actually going to take a second and kind of draw this out so that you guys can kind of understand where we're coming from as far as the different infarction patterns, but I'm going to wait for a few minutes to do that. So this is a left anterior descending occlusion. And you will get a De Winter's T wave in about 2% of the patients. So what is a De Winter's T wave? Well, you guys can read as well as I can, but it is a tall, prominent, and symmetrical T wave in the precordial leads. So the precordial leads are your leads V1 through V6. Those are your chest leads, also known as precordial leads. You will also have an upsloping ST segment depression, which you guys can see here, and then a reciprocal ST segment elevation in AVR. So we're actually going to look at a 12-lead EKG and kind of put this into play. But step 1 here, you have a tall, prominent, and symmetrical T wave in precordial leads. So this is showing V3, so that meets criteria. you're going to have an upsloping ST segment depression. So if we find our J point, we can obviously see it is below the isoelectric line in relation to the TP segment next to it. So this is depressed from here. So step 2 is accurate. And then what we cannot see here is that reciprocal ST segment elevation in AVR. If you all remember back to when you first started doing EKGs, or when we were doing axis deviation, we talked about AVR, and AVR from a pre-hospital and from a 12-lead perspective is always kind of the one that is left out. The only thing that we ever really use AVR for is to see if it is heading in a southerly direction. So is your ST segment actually heading down? And that tells us that our limb leads are on correctly. So if you happen to look in AVR and all of a sudden you see that you have some ST segment elevation, that should be a huge clinical clue to you that there may be something going on, and it's probably related to a De Winter's T wave. So this was I found this interesting as we went through this, because, you know, and even in Dr. Curcio's talk, you know, she goes back several years and some of the things and back to wartime. A lot of the things that we do in medicine have been that way and going on for years, even though we know it's always evolving. The things that we're actually going to refer and talk about today, they're really pretty new. Which may be why some of us haven't been taught this information in the past. In initial paramedic education, we just simply don't have the time. There's too much information that has to be presented in a short amount of time prior to national registry. And you all can imagine if you had to know additional things for even non-STEMI, it would just kind of belabor the process. So this was initially identified in 1947, but it really didn't actually get named until 2008. And if you see a De Winter's T wave, what I would like for you guys to kind of relate that to is an anterior wall MI. So with anterior wall MIs, a lot of times what you guys will find, and this is an experience thing, what you guys will find is anterior wall MIs will look really good. They're pink, they're warm, they're dry, they're talking to you, and then they cardiac arrest. Inferior wall MIs, most of the time, those are going to be your patients that look very, very sick, right? They're pale, they're cool, they're ashen, they're diaphoretic. Those patients, a lot of times, if you can get them to appropriate care in a short amount of time, they're going to end up doing fine. So don't let these anterior or De Winter's T wave patients fool you because you think that they look stable. They are not necessarily stable, and they will go into cardiac arrest pretty quickly. If you have a patient that has an anterior wall MI or has De Winter's T waves based on this clinical finding here, that is an indication clinically for them to have reperfusion therapy. So this EKG alone with elevation in AVR, which we're going to look at, is an indication for them getting an immediate reperfusion therapy. So don't underestimate it. So here's the EKG. So remember, we should have an upsloping and uniform look to the T wave. There's going to be ST segment upsloping, right, in your precordial leads. We have that. And then if we go over here to AVR, and it may be a little difficult for you guys to see, but our QRS complex is heading downward, which is good. But look at your ST segment elevation. And for those of you that are in the class that aren't necessarily familiar with reading EKGs, what I am looking at here is I have my cursor over what I'm going to refer to as the J point, and that is the junction between the ST segment branch, right, on your EKG. So we have a P, Q, R, S, and T that we're always looking at, and that is the junction or the J point. And all we are doing is looking at this J point and determining if it is elevated, equal to, or depressed as compared to the following TP segment where my cursor is right now. So, and what we're also looking for is 1 millimeter. Well, how do we know if it's a millimeter? It's one tiny block on this 12-lead EKG paper, for those of you that are not familiar with reading these. So for those of you that are, you can clearly look here and see that you do have an elevation of greater than 1 millimeter in your ST segment in that AVR lead. So this is an indication that this patient has positive De Winter's T waves. And that is an indication clearly that this person is a good candidate for an immediate reperfusion. So there's my ST segment elevation. And then here is the prominent T waves with my upsloping ST segment depression. If you look at this under normal conditions, if you all made a run today and saw this, yeah, it may look a little funky, but probably what a lot of people would think is, well, maybe it's a potassium thing, because we always talk about hyperkalemia and tall tinted T waves. Well, remember, the evolution of an AMI, or an acute myocardial infarction, is a hyperacute T wave. So don't get caught with thinking, oh, maybe it's a potassium thing, and you send these people packing or on their way, or tell them they don't need to go to the hospital, when in fact they are having an infarction pattern. So please be careful with that. The second one that we're going to look at here is an Oslanger's pattern. And this is more related to inferior wall MI patients. So remember what we just looked at with the Winters T wave, we're thinking anterior wall. With Oslanger's pattern, we're thinking inferior wall. And this is where I actually want to take a second and kind of draw this out for you. So I'm not an artist here, and you guys are going to pick that up here pretty clearly, but I have the heart here. And from the heart, we end up having our aorta. The aorta comes up like this. And from the aorta, we end up having two different branches. There's a branch here that comes off and feeds the right side of the heart. And then there is a branch here that comes off. It shoots over to that side, and then it comes down to the front. So it is amazing how many times I talk to individuals that have been doing this for a long period of time, and especially the student group, that really don't understand what these different vessels are. So this vessel here is the LCX, or the left circumflex vessel. This vessel here is your LAD. And this one over here, that is your right coronary artery. So what I think is important is all of our EKG waveforms and patterns, when we are looking for a STEMI, we always talk about elevation and then reciprocal changes. And I want to kind of point out why that is and why this is important when we're referring to Oslanger's pattern. If I have an occlusion somewhere in the area on my LAD, what I am going to have is elevation in my anterior lead. So I'm probably going to find that I have elevations in V3 and V4. If I have a blockage up here in this LCX, then I know that I have occluded that left circumflex, and the left circumflex is what is responsible for feeding that lateral wall. So I'm probably going to have elevation in my leads 1, AVL, V5, and V6, or at least 2 of them. And if I put the occlusion even more proximal, directly where it comes off of the aorta, now I have an extensive anterior wall MI. I have elevations in 1 AVL, V5, and V6, V1 and V2 showing the septal wall, and then V3 and V4 showing the anterior wall. The one that we have not talked about, though, is the right coronary artery. So I want you to think about this. We always talk about this teeter-totter. Well, this is why we do it. If I have elevation on one side, my reciprocal change will be depressed on the opposite side. And that is because if I am looking at these from this direction and I have elevation, if I'm looking at it from an opposite direction, it's going to show me a depressed segment. So why is this important? What I want you to think about is this. You do an EKG today, and it is showing you that you have an infarction or a STEMI pattern in your anterior leads. Is there any reason to move leads over? You guys can answer that question. Unmute or put it in chat. You find anything in your anterior wall, are you going to move leads over, or are you just going to call in and say, hey, I've got an anterior wall infarct? Anyone? Okay, so Rosalie, you said I'm going to move them the V4R, and that is exactly what I'm talking about, but I'm going to show you why in an anterior wall, we don't necessarily need to do that. So I appreciate you answering, and I can tell you that you're not alone. Even though others did not answer, we find that very commonly, that paramedics will move leads over, when in reality, we really don't need to do that, with the exception of our inferior wall MI. And I'll show you why here in just a second. So I'm going to kind of clear these drawings out to make this a little bit more clean. Okay, so the inferior wall is down here, right? The bottom portion. And there are two different vessels that feed that inferior wall. The number one is the right coronary artery, this vessel right here. The other way that our inferior wall gets blood flow is actually from the left circumflex. So that left circumflex, and it's hard to draw this, so I'll kind of draw it as a dotted line. It basically kind of wraps around the back and then ends up feeding that inferior wall as well. So if we do a 12 lead EKG and we find that we have elevation in leads 2, 3, and AVF, we know that we have an inferior wall infarct, but what we do not know is which vessel did it come from. Is the problem really up here with this left circumflex, or is the problem actually over here in the right coronary artery? The only way that we're going to be able to determine that is to move V4R over. The easiest way, I should say. There are other ways to do that, but moving V4R over and repeating your 12 lead EKG will give you an indication on whether or not it is coming from that right coronary artery, or if it is in fact just part or an extension of a problem over here with that left circumflex. So that's why we do that. Again, continuing education here. Why is that important? Well, the importance comes back to treatment. Remember that if we have a left-sided issue causing an inferior wall MI, we can treat that as a normal STEMI patient. We can give them Mona or Fona, with fentanyl being the other mnemonic there. But if it is a right ventricular infarction, remember, we really need to fill the tank first, and this is why we want to do that V4R, determine if there's elevation there, and then we're going to administer fluids, because we're looking for a little bit of extension in that right ventricle so that we get a harder pump mechanism out so that we can inject blood to the left side. So the difference here with Oslanger's pattern is this is looking for inferior wall MIs. So do your EKGs like we've always done. Move that V4R over if you need to. If there is elevation in your inferior leads, there would not be any reason to take it further with this Oslanger pattern. In the event that your 12 lead looks fine though, that is when we really need to think about applying this Oslanger's pattern if you're going to end up doing this stuff. And again, I always try to be a realist. I know that me doing this lecture here, and especially virtually, and then finishing up here in an hour, and you guys going out and doing this repeatedly and finding things that's not necessarily going to happen. But it's just like the first time you did a 12 lead EKG. If you can remember going back to anything, right? The first time you took a blood pressure, you had no idea what you were doing. You weren't sure, you weren't confident, but you have to just keep doing it and practicing it. So the more that you do and look at this information, the better off and the sharper you're going to be in the event that you have to use it. So about 13% of inferiors present with this Oslanger pattern, and it is also found in about 6% of non-STEMI patients. So of the patients that are showing non-STEMI EKG patterns, this Oslanger's pattern is about 6% of those. Inferior ST segment elevation is isolated to lead 3. So we know that we always talk about 2 anatomically contiguous or 2 numerically consecutive EKG elevations of greater than 1 millimeter. And what Oslanger's pattern is looking at is only in lead 3. So you're going to find that you have an inferior ST elevation in lead 3. You also have ST segment depression in any of V4, V5, and V6 with a positive T wave. And then ST segment in V1 is going to be more elevated than in V2. So we're going to take a look at that as well. How long has this been out? This is actually even newer. So the Winters was 2008, the Oslanger's pattern. They had been researching it for quite a while, but actually wasn't released really until 2020. So if you think about it, I mean, this is really cutting edge information. But what they did is they had 1,000 individuals in a study that they had completed, and they ended up finding this Oslanger's pattern, and that's why the information ultimately was released, because they found correlation. So as we look at this EKG here, remember that we should have inferior ST segment elevation in lead 3. So if we look there and we find our J point, we can see that we do have greater than 1 millimeter of elevation as compared to our TP segment. So that is characteristic. The second part here is we should end up having in our V4, V5, and V6, we should have ST segment depression. And as you look, if I find my J point as compared to my TP segment, I have depression, I have depression, I have depression. That is characteristic as well. And then the final thing is we should come up here and we should look in leads V1 and V2, and you should have a more elevated, your V1 should be more elevated than your V2. So V1 has an elevation as compared to my TP, and V2 actually looks like it has a little bit of depression. So that would in fact meet criteria of V1 being greater than V2. This is a positive Oslanger's pattern, and this is indicative of a patient suffering from an inferior wall MI. The third one here is Wellen syndrome, and this is characterized by either biphasic or deeply inverted T waves in V2 and V3 with a history of recent chest pain that is now resolved. This is the one that I think is probably the most important for us. So you had the Winters with your anterior and the Oslanger's pattern with an inferior wall MI. Those are important, no question. The Wellens syndrome, I think that this is the one that will probably resonate with us more, because they are found in patients that have a pain-free state. And I think that's really kind of the take-home message here, is these are patients that are no longer suffering from any of these acute coronary syndromes in theory. We just can't see it. So these are suggestive of left anterior descending stenosis. And a stenosis, anytime you see the word stenosis, it's just an occlusion or a closure of a vessel, basically. So it is not as big as it once was. So it is stenotic, it's sticky, it's not working the way that it should. But it also may occur in that left circumflex, which goes over and feeds that lateral wall, or the right coronary artery. It does not have to occur in the presence of a thrombus. So normally, under most conditions, why do patients end up having chest pain? Well, because they're not getting enough oxygenated blood through a vessel, because maybe they have a thrombus. And that ends up leading to them having a buildup of lactic and pyruvic acids. And that is what ends up causing their chest pain. But in this situation, it doesn't have to be a thrombotic event. It can just be from a spasm. So a patient that has unstable or Prinzmetal's angina, if you are getting ready to take any type of examination, National Registry, they love to ask questions about Prinzmetal's. Prinzmetal's is another name for spasmodic angina. So all that it is the coronary vessels are actually spasming, and they like to give it a fancy name called Prinzmetal's, and then put it on an exam to try to trick you or trip you up. So it's nothing more than just a spasm of the vessel. Or another situation where this has been linked is cocaine-induced vasospasm. So as you guys may or may not know, cocaine is a potent vasoconstrictor. So if you have an individual and cocaine is on their eyes, in this area regionally anyway, there's a lot of cocaine arrest in prosecution in the Northern Kentucky, greater Cincinnati area. So I'm sure it's the same way throughout the country, but cocaine will cause them to have that induced vasospasm. And then ultimately they may end up showing this Wellen syndrome, typically seen in a pain-free state. And they may have normally or minimally elevated troponin levels. And as I told you, we're going to look at troponin for just a minute. And then an extreme high risk for an extensive anterior wall MI, within subsequent days to weeks. So here's what happens in this situation. Patient has chest pain. We end up showing up and you get there and, oh, my chest pain's gone. I don't want to go to the hospital. We do a 12-lead EKG and everything looks good as far as STEMI. We don't transport them, right? We end up getting called back a week later, a couple of days later, whatever the situation may be, and they're either suffering an extensive anterior wall MI or they're in cardiac arrest because they were in fact having an MI a week or a couple of days ago, and it was missed by us in the pre-hospital setting. So if you think about the T wave, ST segment depression normally starts off because of ischemia. We're not getting enough oxygenated blood to that part of the tissue. If we do not fix that, that depression becomes elevation. And that is where our ST segment elevation comes from, is because we did not fix whatever the problem was leading to that occlusion or the ischemia of that part of the heart. So when we look at Wellens syndrome, and we actually look at this EKG here in just a second, I want to kind of point out that you're going to start seeing some of these EKG changes, and they're kind of going to happen live, which is why we should be doing serial repeat EKGs. So how do we determine Wellens syndrome? Well, it's going to have one of two things. It's either going to have a deeply inverted or a biphasic T wave in leads V2 and V3. So you can see V2 and V3 on both of these examples here. Pattern A, we're looking at biphasic. So what biphasic means is look at my QRS as it relates to my ST segment. So the QRS basically is heading down and my T wave is heading up. So that is biphasic, they're opposite directions. As we look at a deeply inverted T wave, we're still looking in V2 and V3, but you can see the T wave is flipped and it is deeply inverted. So one of these two patterns is what's found typically with your patient that has a Wellens syndrome. So let's look at an EKG here. So you do this 12-lead EKG and it says meets ST segment elevation at 1938 hours. So obviously this could be any one of our EKGs from a patient that we have transported. You do the EKG, it tells you that you have ST segment elevation criteria. You do this at 1938 hours. This is elevation not in our inferior leads. So if I do this, I'm going to go, okay, well, I've got elevation in V1, V2, V3, and V4. So I have at least an anterior septal wall infarct here. This is okay. As long as the patient has a pressure and all that stuff, I can start treating them with MONA or FONA. So I give them either morphine or fentanyl, oxygen, nitro, and aspirin, depending on, allergies and everything else that we should be asking. The patient is complaining of chest pain and has some diaphoresis. So you do a repeat 12-lead EKG at 1953 hours, and you can see the STEMI is really not there anymore. So as we look in our leads V1, and I'm going to kind of jump back and forth here for just a second, look at lead V1 now, and look at what lead V1 was then. V2, V3, and V4. Same thing here. We look at lead V2, we look at V3. V3 does appear to be maybe a little elevated, but then we look at V4, and we can see that elevation is no longer there. The patient is pain-free at the time of the EKG. So what is important in the take-home message is this. Maybe the patient did not necessarily call you. Maybe the family member gave them aspirin, or the patient is a prior cardiac patient and they went ahead and took their nitro and they took their aspirin. And then we get there 15 minutes after they're having chest pain. They tell us, I don't have pain anymore. My pain, I did have it, but I took some nitro, I took my aspirin, and now my pain is gone. Maybe we do a 12-lead EKG and it looks like this. And then ultimately we tell the patient, I don't see any STEMI pattern here. I think that you're okay. Follow up with your doctor, call us back tomorrow, whatever the deal is, when in fact the patient is in fact having an infarction pattern. So you can see here the deeply inverted T waves for sure. and the biphasic T waves that go along with a patient that is having a Wellen syndrome. Same thing here. As we look, you can see that these T waves become very deeply inverted, which is problematic and indicative of the patient having a Wellen syndrome. So please do not get caught with your guard down in these situations. These patients should probably be evaluated at a reperfusion capable hospital. So there's your deeply inverted T waves, and on the previous one, I'll go back here, you have your biphasic T waves as well. So the Wellens timeline, just to kind of go over what we've already mentioned, sudden complete occlusion of the left anterior descending. So that LAD, remember, feeds, depending on where it's at in the LAD, it feeds the circumflex, which is your lateral wall, it feeds the anterior wall, and it feeds the septal wall. So a sudden complete occlusion of the left anterior descending causes a transient anterior STEMI. The patient has chest pain and diaphoresis. They either take their nitro and aspirin at home, or we get there and we give that. The LAD leads to resolution of chest pain once we clear that up, and the ST elevation improves, and the T waves then become biphasic or inverted. Remember, that's all changing because of the ischemia pattern. If that artery is going to remain open, the T waves will go from that biphasic appearance to deeply inverted. If they do not stay open, then what's going to happen is they'll go from that biphasic and deeply inverted, and then ultimately flip and become an elevation. So it may look, and this all becomes, what time did you do your EKG? Because what we may end up finding in the field is that everything looks normal. The T waves begin to normalize, right, in quotations, before they become hyperacute as seen in a STEMI pattern. So I can promise you this has happened to people that are on this lecture today. Not necessarily that there was an appropriate treatment or you didn't transport, but we have gotten there at the time where we do the EKG and it looks normal, when in fact it really isn't normal. We just happened to get the picture at the wrong time, showing us that things had normalized when in fact they were in transition from being deeply inverted or biphasic to elevated, and a STEMI pattern being seen. So what about troponin? Well, there was some feedback months ago, and we've tried to do this if there are blood lab values that relate. But I think this is an interesting point that was brought up by an individual, and I appreciate that, is we go into the hospital, and I think that the hospital and the ER staff, oftentimes they think that we speak the same language as they do, and that is not always the case. So you guys can appreciate that you transport a patient in with some chest pain, and maybe it was an interesting patient or somebody well known in your community or whatever, and then you go back to the hospital 2 hours later on a different call, and maybe the nurse or the doc says, oh yeah, we did some labs and their troponin was whatever. And we always just kind of, oh, okay, yeah, that's great. And maybe we really don't even know what they're talking about. So if we're talking specifically about blood test as it relates to the lecture that we're in, we're trying to go over some of that just so that you all have an idea of what they're talking about in the emergency department. So there are three different types of troponin. There's troponin C, T, and I. And the troponin I is the one that is used for cardiac troponin. So if you go into the ER and the nurse says, yeah, their troponins were elevated, they're actually referring to troponin I, because we really don't talk so much about C and T, even though they do relate to cardiac. It's the troponin I that they're actually looking at when they're referencing what their ranges are. So blood tests, and if you've been around for a while, we used to always call these either CKs or CKMBs, and that was creatinine kinase. But the problem with CK and CKMB is they're not specific to cardiac muscle. So let's just say that you got up this morning, you went to the gym, you worked out, and then you end up in the emergency department for whatever reason. They do a blood test on you, and all of a sudden your CKs are elevated. Well, your heart is in perfect condition. There's nothing wrong with your heart. It's the fact that you were at the gym this morning and now you have muscle breakdown. that's going to end up buying you an admission into the hospital so that they can rule out heart problem. With Troponin I, it is specific to cardiac muscle. So if you have elevations in your Troponin I's, it is actually coming from the heart and not necessarily from the leg or back or arm workout that you did this morning. So what troponin is actually a protein that's found in cardiac cells, and it is released if there is damage to those cells. And it doesn't necessarily have to be that they're having an MI. It could be that they've had SVT. It could be that they have a pulmonary embolus. So anything that puts the heart under additional pressure or stress is going to end up causing a release of this protein that's in the cardiac cells called troponin. It typically will elevate within 3 to 4 hours of a patient complaining of chest pain or an MI, but it can remain elevated for 10 to 14 days. So normal troponin levels, and this changes based on lab to lab, but a normal troponin level is 0.04 to 0.40 nanograms per milliliter. A nanogram, just to put this in perspective, is 1 billionth, and that's with a B, of a milligram, 1 billionth of a milligram. So it is a very, very, very small number, and there's typically no troponin found. If, for instance, let's say that you have SVT, you might see that they have troponins of 10, something like that, because their heart is working harder than what it should normally be working. That would be kind of a normal finding. If we start seeing troponin levels in the hundreds, there's probably some sort of damage that is actually going on, and they're going to obviously be sent to a cath lab and have that investigated further. So troponin levels, I talked to somebody yesterday, actually, they had a patient with troponin levels at 900. So you can see this 0.04 to 0.40 up to 900, and it can go higher than that. But if they have troponins, in the hundreds, there is definitely something going on in that situation. So when you're talking to your ED folks, hopefully now you kind of understand what troponin is and where it comes from.